So all women of all ages, when you first come in for your initial visit, you will get blood work done, and you know why. Well, we're testing a lot of things in that initial blood work. We want to look at your chemistry, your blood count. We want to look at blood-borne diseases. We want to look at your blood type. We want to look at things such as rubella immunity and other factors that can make us more suspicious depending on your line of work, who you come in contact with, where have you lived, and things that we look from that infectious standpoint, what we can test you for. And then there's other specialized tests as well. So in talking about family history and your personal history and your ethnic background, again, when you come into play about different things that, more advanced screening of things and conditions that we would like to test for. And one of the most common ones is cystic fibrosis carrier gene screening, and that's something that's done pretty early on with blood draws. And it looks at the mother's carrier state of cystic fibrosis. We also look at Fragile X syndrome, and that's not for everybody. It's more for women that have, or there's a family history of autistic disorders, ataxia, and after age 50, and various multiple things that we kind of question about, or really early menopause in some women, and infertility and issues like that, but most commonly mental retardation, or that is in the family that we can look for Fragile X syndrome. Sickle cell and blood disorders like thalassemias is something that we screen for as well, and spinal muscular atrophy and conditions such as spinal muscular atrophy and weakness that we want to test for as well. And again, those things are are determined. We don't just test everybody, determined on specific risk factors. So the decisions for special genetic testing, like I said, they're based on family, personal history, ethnicity, and personal choice, because unfortunately, as great as we are about a lot of these genetic defects that we can figure them out, we have no way of altering them, so the information is really information. So, then there's also other options to talk about with testing for the fetus. So in terms of genetics, then there's genetic things that we pass on to the baby, and then there's what is the genetic makeup of the baby itself, and was it normal, is everything progressing okay? So we really look at screening for the babies, or screening or testing for these what we call aneuploidies, or chromosomal numerical abnormalities, or chromosomal structural abnormalities, divided into two big categories, whereas there are invasive tests and then there's non-invasive tests, and that's how I always explain it. Non-invasive testing is a screen. The screen is something where I'm looking at the likelihood of this disease processing occurring to an individual at a certain accuracy, where I'm only going to give you 90 to 94% accuracy with that. It's not 100%. Nothing really is 100%, but non-invasive screening tests are tests that look at blood work and ultrasound parameters to give us an idea if things are progressing regularly. Whereas invasive testing, such as chorion villi sampling and amniocentesis, are tests where they're actually going into the amniotic fluid, sac of the baby is in, and removing that amniotic fluid to look at the chromosomal array of that child. So this is 99.9% accurate, where they're looking at those chromosomes to tell you they look normal. But there's drawbacks to anything in life and any kind of choices we make, and with amniocentesis and chorion villi sampling, and the difference between those two is chorion villi sampling is done at an earliest stage in gestation, whereas amniocentesis is done later, is that there is a possibility of disrupting the pregnancy. And yes, you can have a really normal pregnancy, but because of the test intervention, that pregnancy is either cause a complication from either ruptured amniotic sac or infection. So there's complications. Whereas non-invasive tests, yes, it's not 100% accurate, but there is no detrimental effects that can occur to the pregnancy itself. So, so what we have at our disposal is fetal ultrasounds is employed with the following things. So what we do is a sequential screen. Is one of the first markers right in the very first trimester, almost the second 12 to 13 weeks or so, looking at the thickness of the baby's neck, basically the fold in the back of the baby's neck. That is a nuchal fold that we call the nuchal fold, and there's measurement parameters that are also combined in calculation methods with blood draw from the mom to look at, again, any of the likelihood or possibilities of an abnormal test. And then after that, there is a second blood work draw, and then those two tests are looked at and combined to give you a risk parameter. In the second trimester, there's also a ultrasound that we do, and it's called the survey, the anatomy survey. And we look at all the body parts of the baby and the heart and the lungs and everything for developmental parameters to see that everything is progressing or developing normally. And blood enzymes are also used, again, for neural tube defects, and alpha fetal protein is one of the proteins the baby makes, and that's something that we will also look at to see if there's any fusion problems with the neural tube. And those are all the things that we have at our disposal that are tests that are not invasive but are done, and they can be easily done just on blood work from mom and ultrasound. And now there is some testing and research done that there is out in the community, and scientifically there's been tests to look at isolating from maternal blood fetal DNA to see if there can isolate fetal DNA and test that for actually chromosomally testing it for Down syndrome. Nothing is really anything that we can use right now. It's all in testing phases, but it's looking more promising. However, it's all research. So because we're trying to get measures where we can just not cause any harm to the pregnancy, but yet get more accuracy in testing, and that's where that's stemming from. After we talked about all of this genetic testing and counseling, and we also have you see a geneticist if there's any high risk measures that we identify in addition to all this. After we've gone beyond those points, after 20 weeks or so, we start to go into this regular mode of seeing you quite frequently and kind of talking about different testing parameters. So other things that can happen in pregnancy that we always worry about is gestational diabetes, gestational hypertension, or pregnancy-induced hypertension, actually. And so, kind of walking over to your ability to shape your child's life inside you in terms of diabetes and hypertension. So gestational diabetes is tested about 28 weeks, but not everybody. Some people are high risk, they get tested early. Or if you are a diabetic, that's something that we have to kind of treat you with and manage you with throughout the pregnancy. So that's another thing that we do. But for anyone else that doesn't have diabetes or any history there's no risk factors, will get tested anyway at 28 weeks, and that's when you get that sweet 1 hour test with the sweet little jug that you drank, and everyone gets nauseous after. But that's exactly what we're testing for, and we're looking at your ability to combat that sugar with an insulin rise to see how high your index sugar goes when you have that extra test load. And I'll explain why that's important. So as the pregnancy progresses, again, eating habits and maintaining good weight gain without excessive weight gain is really the key. Because yes, we can predispose our children to becoming diabetic and becoming more obese and it's from birth. And so that's important that we do shape them. We do kind of create an environment for them. And here's one big baby. He's really sweet. And he's really chunky. He's a big baby. I don't know the record highest birth, but I think it's way over 10 pounds that they've been able to deliver. So, that's not something we really want. But in spite of, so we're talking about this in terms of gestational diabetes and why is that so important and these babies get so big, is that as we ingest sugar, the sugar gets passed down into the placenta straight to the baby. It diffuses right into the baby. The baby has its own insulin and pancreas. It will combat that sugar with its own insulin and react as insulin is just as fine. But the problem with the insulin, it keeps secreting because it's trying to overcome that sugar spike, is that it's kind of similar to a growth hormone for it. So it can start to develop bigger and bigger because that insulin promotes now, and it looks shapely, the molecular size like a growth hormone. So the baby starts to put on weight. And not only does it start to put on weight in certain areas, it starts to put on weight more in the shoulder distribution as well, because we believe that's part of that growth hormone interacting with its own insulin. And then we worry about, this obstetrical complications with delivery of these babies, such as the shoulder dystocia, meaning the shoulder being stuck out, during the delivery time, because of that larger deposit of fat in that area from gestational diabetes. So that's why we get so on top of trying to treat this and maintain your sugar levels at a normal and don't have those high spikes, because the baby will spike its own insulin for that and can create this process. So that's sugar testing and gestational diabetes we talked about. And the other things that we look into that I wanted to kind of add into a blurb here is, which we probably should talk about around this time, because it's a good time to start thinking more proactively about pregnancies. There is a lot of cord blood banking that you'll hear about, whether in Florida we don't have private banking, we don't have public banking, we have only private banking is what I meant to say. And it is something that's a service that's costly, but there is some things that are beneficial out there in terms of study for, in regenerative of these stem cells that could be, promising. So, but really, honestly, this is something that someone that, as a couple, should look into. The likelihood of need of stem cell transplants for a child from its lifetime is still about 1 in 1,666, so it's not high. But in terms of families that have blood cancers such as leukemia and lymphomas, or have any other serious genetic defects, sickle cell, anemia, that could be an actual important parameter to have blood banking as an available thing for them. Because again, not only has there been more advances in stem cell research, also for CP, in terms of babies born with brain damage and anoxic brain damage or low oxygen brain damage. There's been another study out there that's been ongoing for that kind of progression and brain trauma and so forth. But those are the extra things that we should definitely look into, and I do not promote any company or there are other options that we can look into. So as you progress into the 3rd trimester, there are more frequent visits and monitoring until delivery. Hopefully you won't have 8 babies at delivery, but as you progress, we're watching your weight, we're watching your blood pressure, because there's a couple of things in the 3rd trimester that tend to sneak up on us, and one of those is pregnancy-induced hypertension, or as that progresses into more of taxemic state with more swelling and elevated blood pressures. That's something that we monitor closely. At 36 weeks, you almost see us every week. For to making sure that you and the baby are doing well, the baby's progressing in its growth curve, you're doing well, your blood pressures are not elevated, and we also check you to see for cervical dilatation, and depending on your symptoms to identify signs of labor, and that's throughout before that. Obviously, if there's any preterm labor, we would take care of that.